Welcome everyone, and thank you for giving up part of your evening to attend tonight's webinar on the Simplified COVID Contracts being offered to BC physicians. My name is Sharon Shore. I'm the Senior Manager of Communications and Media Relations for Doctors of BC, and I will be moderating tonight. So you'll be hearing from Mr. Paul Straszak, our Chief Negotiator. Paul and his team have been consulting with government while these contracts were in development. You will also hear from Mr. Mark Armitage. He is the Assistant Deputy Minister of Health, and he led the development of these contracts. Also tonight, we have Dr. Trina Larson-Souls. She is chair of our Statutory Negotiating Committee, and she was involved with the contract discussions as well, and Mr. Jim Aikman, our Vice President of Economics, Advocacy, and Negotiations. Please know that your video and audio are turned off, so tonight our format will be as follows. Paul will spend a few minutes talking about the contracts overall, and then he will hand it over to Mark, who will speak for about 15 minutes, providing greater detail. After the presentations, we will open it up for questions and answers. At the bottom of your screen, if you hover your cursor, you should see a couple of icons, Q&A and chat. So if you're having technical issues or other concerns, chat is where you'll let us know. You will use Q&A to type in any questions you may have, but please don't use chat for questions. Feel free to type in questions as Paul and Mark are speaking, but I will relay them after the presentations are complete. Questions will be posed to Mark, and Paul and Trina and Jim will add anything they think relevant. Questions can be asked anonymously if you prefer. That option is in the Q&A box. Even if you don't have a question, feel free to click on the Q&A icon to see the questions that are being asked. As a note, this webinar is being recorded and will be made available to anyone who would like to view it later on. So I think it should all be pretty straightforward. If you have any questions about the process before we start, please type it in chat or Q&A right now. Okay, so seeing nothing, let's get started. Paul, the floor is yours.
Thanks very much, Sharon, for the introduction, and thanks to all of the physicians on the call for joining us for our briefing on the new Simplified COVID Contract. This is a contract developed by the Ministry of Health in consultation with Doctors of BC as an alternative to fee-for-service compensation that is specifically designed for those physicians whose incomes have been significantly affected by reduction in service volumes as a result of the pandemic. I'll start by providing you some background on Doctors of BC collaboration with government, and then Mark will take you through an outline of the contract terms and the implementation plan. Shortly after BC began preparing for the impact of the COVID pandemic in spring of this year, the CEO of Doctors of BC engaged senior officials at the Ministry of Health to develop collaborative strategies to assist physicians to effectively address the healthcare crisis. Among the issues discussed was the need to address the impact on physicians of reduced demand for clinical services during the pandemic. The ministry agreed to work with Doctors of BC to develop a suite of compensation options available to fee-for-service physicians to address the issue. Our initial work was directed to developing new fees to facilitate virtual and telephone care to stabilize the practice for many physicians. Additionally, hospitals have now reopened and have rescheduled surgeries with the intention of catching up on the volumes lost in spring. Our data now shows that most physicians have been able to rebuild their service volumes after the first wave of the COVID impacts. However, both the ministry and Doctors of BC remained concerned about the potential that another wave of the pandemic may result in another significant reduction of service volumes that would undermine physician practices again. Many of our members called for an hours-based payment scheme as an alternative to fee-for-service that would provide them with a more sustainable source of income through another wave of COVID pandemics. Next slide, please. Over the course of the summer, we discussed this option with the ministry, and they agreed to consult with us and get our views on a new hours-based payment model to be offered as an alternative to physicians whose incomes have declined significantly in the face of the pandemic. Doctors of BC board asked our Statutory Negotiations Committee to represent physicians' interest in the consultation process. This is the committee whose primary responsibility was the negotiation of the last Physician Master Agreement. Dr. Trina Larson-Souls, who's joining us on this call, is the chair of the committee, and the other members are Dr. Jaime Fox, Dr. Fred Kozak, Dr. Michael Moran, and Dr. David Wilton. We are also joined on the committee by Jim Aikman and Todd McPherson from Doctors of BC. As Sharon mentioned, the ministry team was led by Mark, Assistant Deputy Minister from the ministry, and he was ably assisted by Marie T. and Ina Ackerman, who are also on the call. We are able to conclude our consultations in late August, and the ministry is now prepared to offer most physicians a new simplified COVID service contract as a new alternative for those fee-for-service physicians whose services may be significantly compromised by the pandemic in the future. And what I'll do now is I'll turn the presentation over to Mark, who will outline the key provisions of the contract.
That's great. Thanks, Paul. And can I just confirm that you can hear me okay?
Yep.
Okay, perfect.
Yep.
So before I go through the presentation, I just wanted to say good evening and thank you for taking the time out of what I can anticipate has been a long day. It's a pleasure to be with you this evening, and just also want to extend hellos and thank you from my Deputy Minister, Stephen Brown. He's aware that we're doing these webinars, and just wanted me to pass on his thanks to all of you for the continued service that you've provided through the spring and through the summer and now into the fall in what are unprecedented times. So this evening we're going to walk through the elements of the contract. I'm going to try to go through at a fairly good clip because I think the main purpose is to try to get into some of the questions that I'm sure many of you will have. But just to sort of lead us off, I'll kind of walk you through some elements of the contract. So the first thing I just want to point out that this is a simplified version of the AP service contract from the PMA, and that's been done purposefully to try to make it as simple and as straightforward. You know, when you stop and you think about the number of sections that are potentially wanting to access the contract, if we had taken a sort of a tailored approach on each template, it was going to take months for us to work through the consultation and discussions with the Doctors of BC. So we agreed early on that we try to work from a sort of a base template, and we try to make the process as simple for everyone as possible. Just like to point out that this is actually a contract between the physician and the health authority, but just to be explicitly clear, this is actually a product, the contract template itself, that's ostensibly owned by the ministry and is been developed through consultation with the Doctors of BC. So there's minimal local negotiation required in moving on to this contract. And if, as time goes on, there are systemic issues that are identified or things that we need to address with the template, the ministry has committed to the Doctors of BC to engage with Paul and his team to talk through those issues and look for the best way to resolve them. The next sort of key point here is that the services in this contract are really intended to be the ones that have been historically provided by physicians. So this isn't a contract for you know, pivoting solely to a virtual option or expanding what physicians would typically do within their section. It's really to kind of find a balance and create both the opportunity for direct patient care and also virtual care. I think one of the key elements of the contract, though, is it was flagged early on that because of the pandemic and particularly for proceduralists, there may be a need to rethink how services are provided, you know, how patients flow into a physician's office, how a procedure is done, how services are clustered. So we made the conscious decision to allow for up to 5% of the hours within the contract to be used for service redesign. So those hours can be billed at the clinical rate of the contract. And it's really to create the opportunity for physicians to get recognized for the time that's required to perhaps rethink how services can be provided and maintained during the pandemic. Now, as far as the payment itself, as Paul mentioned, this is a time-based, it's an hourly rate contract. The rate is based on 90% of the PMA service contract maximum for each practice category. You know, if you are unaware of what those rates are, we can certainly make that available through the Doctors of BC. And it's based on one full-time FTE being 1,680 hours. So, you know, essentially it's 90% of the category based on 1,680 hours. You take those two and you divide them and you end up with an hours figure that a physician can bill for their time. One of the issues we talked about as we went through that is that for some physicians, they may have the interest in working greater than 1,680 hours. So what we've ostensibly arranged is that for physicians can actually bill up to 1,867 hours within the contract within a year. And that's to allow for those physicians who, for whatever reason, may wish to work greater than the 1,680 hours, and it recognizes that time and pays at that clinical rate based on the methodology that I outlined just a minute ago. And in addition to that, physicians may bill some fee-for-service additionally for WorkSafe services as well. Now, the contract itself doesn't replace the issue of overhead. So physicians are required through this payment option to pay their own overhead. So that's just, we just wanted to be sort of upfront about that and how it's structured. Now, with respect to the length of the contract and the termination notice, the contract, this slide, I should have actually corrected this, so my apologies. It should say the contract maximum term to start is up to December 31st, 2021. You know, what we are committed to doing is making this an option available during that time. So physicians anywhere between now, sort of early November and through to December of 2021 may go on to this contract. The end point at this point that we've agreed to with the Doctors of BC is December 31st, 2021. So if you went on in January, for example, it would be a 12-month term. We have, however, agreed that we would reassess in the fall of 2021 where the province is at with respect to the pandemic, what the circumstances are occurring with respect to any sort of vaccine that might be available, with respect to how services are being provided. So while we have an initial term, I don't want to leave the impression that it's simply going to end at the end of the calendar year 2021. You know, if the circumstances support it, then the ministry is open to extending it. How long that's extended for and what that would look like is premature to speak to, but we have made the commitment to work through that with the Doctors of BC. The contract does include standard termination with 60 days notice. But in the event that, you know, a physician is on this contract and for whatever reason decides it's either not a good fit or has found that they've been able to adjust their practice in a way that they want to move back onto fee-for-service and continue to provide the same services, we've allowed for an expedited termination clause so that you can exit the contract within 5 days. And that's really to recognize that some physicians you know, may find that fee-for-service actually is their preferred method, and as long as they're providing the same services and providing those services to the public, then we want to create the ability to move quickly. In this contract, there is a requirement that physicians bill and assign to the health authorities. And that's really done for a couple of reasons. It's one, simply so that we can track the services that are provided, similar to how we do now under fee-for-service. Having bill and assign is actually a fairly common practice with some contracts. So it's not a unique characteristic that we're just introducing. It's a method that's used. And it also helps us on the backside, on the financial end, to be able to determine what type of budget transfers we need to do to the health authorities so that they can provide the money to physicians who are on this contract. Now, as far as who are the contracts available to, they're extensively available, as Paul said, to the majority of physician groups. That includes all family physicians. There may be family physicians on this evening, I'm not sure, but you're probably aware that we have introduced in this month the contracts for existing physicians who want to move on to a group contract, and the refresh version of the new to practice contract for family physicians. So this is simply another option that we're making available. And then for all specialists, it's available except for anesthesiologists, because we're in the process of rolling out an existing new contract option there. And for ER physicians, we have an existing standard AP contract for ER services, and we thought it was more beneficial simply to stick with existing options there that are utilized and people are familiar with, rather than introducing another option. And so that really is the contents of it. Now that's quick, and I'm sure there's probably questions that folks have. So we're very happy between Paul, Marie, Ina, and Jim and I to respond to the questions. So I'll hand the moderator role back to Sharon, and I'll stop sharing my screen so that we can all see each other. Thank you.
Great, thanks very much, Mark, sorry. So we have a number of questions. Just so you know, if you think of a question after this webinar is over, please email it to negotiations@doctorsofbc.ca and you will receive an answer. And please know that if your question is more complex, the regional advisor and advocate in your area may reach out to you directly. We have an RAA in each health authority, and their job is to support physicians in their communities and are the first point of contact to assist you in seeking services and support from Doctors of BC. So let's get started with your questions. Can you please confirm that the classification of the hourly wage payments by the ministry will not be classified as an employee-employer relationship, resulting in T4s being issued for the hourly wages paid? It is important that payments are not described or classified as wages salary to maintain independent contractor position with the CRA.
I can take that one if you want, Mark. What we've done is we've used as a basis the service contract template that's in the PMA, and that's been well established as something that makes clear that the relationship is one of independent contractor to contractor. It absolutely steers clear of the considerations that would cause a person to be deemed as an employee. So that's not a concern under the contract, and it's actually quite clear in the wording of the contract as well.
Great, thank you. What happens if I work at more than one clinic?
Well, I'll have a stab at this, and then I'll let Paul weigh in if he wants to add anything to it. But, you know, this is a contract for the provision of services. And if you work in multiple different settings, that doesn't impact, from my understanding, your ability to bill against it. So if you have if you're providing services across 2 or 3 clinics, it doesn't really matter. What really matters is that you're providing the services and that you're accounting for that time, and that you're doing the usual billing process, the bill and assign process.
Mm-hmm. Yeah, our understanding as well is that what would happen is there'd be a commitment by the physician to continue all of the fee-for-service services that are provided under the contract. and the contract requires the recording of details associated with those services. And as long as they're recorded, they'll be paid by the hour. But it would include all of the fee-for-service services that are being provided by physicians.
Thanks. And this is a related question, I believe. I work at Clinic A as a family doctor and pick up walk-in shifts at Clinic B. How do I bill at Clinic B on the contract?
Yeah, as I said before, the notion is that all of those services would be covered under the contract. So it's a decision that a physician makes to replace all fee-for-service with contracted hours.
Thanks. When can we start the contract?
We're targeting making them available this calendar year. The issue that we're unsure about, just to be completely transparent, is what will be the interest or uptake on it. And so we are interested to find out, sort of post this webinar, what type of interest is expressed. And we have had some conversations with the doctors of BC that if the interest is greater than our initial capacity to respond, we may need to think through how we might prioritize it. We're still early days on that, but our intent is to make them available before the end of the calendar year. I would assume that's going to be within November, but there's just a few details that we still need to work out. We have been in the background working with the health authorities to increase their capacity to be able to support these contracts. And we've been doing the same at the ministry with our own staff. So I think that we're reasonably prepared. But again, it's just going to depend on sort of volume and our capacity to respond.
I just do want to add to that. We specifically designed the contract to minimize the kind of local negotiations that may happen between physicians and health authorities. The hourly rate is determined, the services are determined, the hours are determined according to the hours that the physician can work. And so what we've tried to do to simplify the application of this contract is to absolutely reduce the kind of things that would be individually negotiable. And that'll assist in a relatively quick take-up of the contracts.
Thank you. And are the contracts backdated?
No.
Is MOCAP paid in addition to the service contract?
I'm going to turn this one over to Paul.
Yes, a MOCAP agreement is separate and continues on while this contract is in place. So a physician maintains the call obligation in accordance with the historical practice, and will continue to be called in. And when called in, that physician would bill the hours under the contract. Under the contract, to the extent that that physician provides services at the end of the telephone, those hours would be covered as well.
Okay, thank you. What if I have a part-time private service practice, cosmetics, etc., and I'm a bit concerned with the wording as to what constitutes a third-party billing?
I'm not sure, Paul, if you want to comment on that, or I might ask Ina to comment on it.
So first thing I'll say is the only billing for public patients on the contract that's allowed and paid under fee-for-service is for WorkSafe BC. I would imagine, and perhaps Ina can comment on this, that the contract would not be extended to cover whatever private services may be provided in a private clinic, simply to continue the commitment that the physician has made to the ministry, to the government, to the public, through the public purse that they've been doing historically. But perhaps, Ina, you have more details.
Yes, I mean, the contract is intended to be with respect to the services that the physician is providing to the health authority, in effect, to the public system. And so if they have and so the contract would cover that. And so any The contract allows physicians to retain WorkSafe billings from those services, but other third-party billings they would have to assign in respect of those services they're providing to the public system through the health authority. If they have a separate private arrangement, in my view, that would not be covered by the contract because it wouldn't be included in those services, and therefore those could be billed separately. The contract specifies that you are able to bill fee for service for anything that's actually outside the scope of the services covered by the contract itself.
Thank you.
And I think just to add to that, it is possible if you want to continue to do some private work and to be on this contract. They just can't blend in any way. So you can sort of balance those two if you choose to do that.
Okay, thank you. In reference to Article 5.1b, why are non-insured services not able to be retained by the physician?
Okay, so I might ask Paul or Todd or Ina to weigh in on this one.
My answer is fairly simple, because that's what we've agreed to in the contract.
Okay, thank you. My main question, which hopefully will be answered, is how the hourly wage will work given that this contract is designed for reduced visits. So if we schedule to work for 3.5 hours, but only booked, for example, for 2 of those 3.5 hours, are we paid for the time we are scheduled?
So maybe I'll jump in as well. The payment under the contract is based on hours worked to provide the services. It's not based on scheduled hours or an intention to provide the services. It's based on the actual time providing the services. And so this, in such a case, if you worked longer than the scheduled hours, you'd be paid for those hours and report them according to the services provided. And if you worked shorter, you'd be billing less hours. But a note here is that the breadth of services covered is relatively important. We're talking about direct patient care, including things like time spent donning and doffing personal protective equipment and waiting for the operating room to be cleared of aerosolized particles, and other direct patient care. Indirect patient care covering a full range of services, including reporting of hours, including reviews, analyses conducted to support the patient care that's provided. Clinically related teaching and clinically related research as well. So a full range of those administrative services that many physicians have felt were not perhaps adequately covered under fee-for-service are covered to the extent that they're related to clinical services under the contract. All that being said, though, physicians must report on the hours worked, and that's what determines the hours that are paid.
Thanks, Paul. My understanding is that it was 90% of the midpoint of the service contract range. Is that untrue? The slide suggests that it is 90% of the maximum of the service contract grid range.
Yeah, so the service contract range in the PMA is outlined by a maximum and a low point, which is 80% of the maximum. So 90% is at the mid-range. So it is 90% of the maximum annual rate, divided by the minimum number of hours that a physician can potentially work under an alternative paid contract. So 90% of the annual rate divided by 1,680 hours, and that produces a single hourly rate that is applied to each contract, and it differs based on the practice category. On our website, you'll see a link to a page which identifies the specific hourly rate that is paid under the contract.
Thank you. Assignment to fee-for-service to health authority. Presumably this is just for BC MPS fee-for-service fees, not the private billings of physicians.
To the extent that it is a private service, not in the public system, that won't be included. But if it is any service provided under the public system, there is a responsibility to assign that work to code it and assign the payments to the health authority.
Okay, thank you. Can complex care and CDM incentives fees still be billed?
Now, I'm not certain about that. Maybe perhaps Todd and Ina can come in on that question.
I'm a little unclear, sorry, I'm a little unclear on what those fees are.
Jim, do you want to answer?
Go ahead, Todd. Sorry, these are annual payment fees for managed care of complex patients and patients with chronic diseases. They are to be billed and assigned to the health authority if you're working under this contract.
Okay, thank you. What happens if we need to work more than 1,867 hours per year in order to care for our patients? Do we work for free over and above 1,867 hours? Most surgeons work far in excess of those numbers of hours per year.
My comment is that as a result of our consultations, we determined a high-end figure here. I'm not sure about flexibility beyond that, if there's a need for the services. I have to say that our sense in a COVID environment where there was a limitation on demand, our sense is that if the hours were greater than that, then it would be very unlikely that this kind of contract would present a reasonable alternative to fee-for-service. So I'd find that an unlikely scenario. However, the contract does include a maximum hours rate.
I think the additional piece for me, and it kind of picks up on Paul's comments, was that the genesis of this contract option was specific to responding to the pandemic, to provide some income certainty for during significant slowdown, and also to maintain public services. It's not meant as the tool and mechanism to create a broad AP contract for the outside of that context. There will be learnings that come to this, and it may be that through that we do need to develop a different approach around AP contracts for different sections. You know, if there's interest, or if we find through the learnings that there's challenges with this one. But to Paul's point, these were developed within a very specific set of parameters in response to the pandemic, and they're not intended to be a solution to a broader interest of moving over to an AP contract option.
Thank you. Is this contract available to those new in practice?
What we've done when we define the services is we've defined them so that physicians who are already in practice commit to what they have historically provided to the public system. But there's also an opportunity for physicians that are new to practice to take on the contract if they provide the kind of service that similar physicians provide on a fee-for-service basis. So there is the opportunity to do that, but I imagine it might take a little bit more conversation to accept a new to practice physician under the contract.
Thank you. Are payments for research excluded or not?
Payments for
Research, yeah.
For research are included in the contract. So teaching and clinical research are included to the extent that they consist a part of the current practice or the historical practice of physicians.
Thank you. What does 90% of range mean?
So as I said earlier, there is a range under the PMA that we are borrowing to determine the payment range under the contract. And it ranges from a maximum point and a low point of 80% of that maximum point. So 90% is midway through that range. And that's the rate that would apply here. Just another point here is to say that while we've identified that 90% point, we are still engaging in processes under the PMA that are to allocate funding to the early years of the contract. And we have recognized that that funding is going to be paid retroactively. So to the extent that you see the rates that we've published on our website, those are going to be increased retroactively once a decision is made to allocate funding through the allocation committee and the after hours committee. So some practice categories may increase, some quite significantly.
Okay, thank you. I recognize the contract is to compensate for lower volumes. Can you confirm that there is no penalty for low volumes identified on tracking? That is, what if only one patient comes in 1 hour?
So there may be a range of responses on this, but the payment is directly related to the hours of services that are provided. If one patient comes in and we see the patient for 1 hour, that's 1 hour of services. And there may be other related services that may also be billed under the contract to the extent that there's reporting and review and work associated with the redesign of the office. But the funding is related to the time that the services are provided under the contract. And so simply because an office is open for 8 hours, that does not allow for 8 hours worth of billing. It does provide the physician some flexibility, however, to undertake clinically related practices that are identified under the contract within those 8 hours.
Okay, thank you. Are OR surgical assist fees assigned to the health authority as well?
That sounds like there's a technical twist to that. So perhaps some of the other experts on the call can help me with that.
Yes, I believe that the surgical assist fees would be assigned to the health authority as well.
Okay, thank you. Is this a group contract for multiple physicians at a clinic or an individual physician contract?
This is an individual contract. There may be circumstances where if a group of individual physicians are seeking to participate, that be recognized as a group. My own view is that's probably not necessary because we are seeking the flexibility for an individual physician to make a determination that that physician wants to shift off and go back to fee-for-service at an appropriate time. However, we did discuss the potential of arranging the contract as a group contract, but fundamentally, it's designed as an individual contract for an individual physician.
Okay, thank you. If I work across multiple health authorities and only one part of my practice has had a decrease due to COVID, could I do a blended fee-for-service and hourly model? For example, hourly for work at PHC and then fee-for-service at other health authorities?
Well, I can say we haven't considered that, so I'm not certain what the ministry would be and the health authorities would be prepared to do. That does pose an issue, however, because the whole idea is for the contract to be signed by a health authority and a physician, and to the extent that there are multiple health authorities involved, then that might require a little bit of rethinking. So I don't know, Mark, I think we'd have to think a little bit about how that might work.
Yeah, I think we'll have to take that one away. But as I understand the question, it's, you know, if I want to go on to the contract and attached to a health authority and continue to do some fee-for-service work that may be attached to another health authority, is that feasible? So we'll take that away and talk amongst us, and then we'll provide a response on that one.
Okay, I think we'll have to include that one in a Q&A.
Yeah.
Thank you. So what would be a representative pay amount for a family physician? I don't recall a particular amount being said.
Okay, let's see if I've got it here. I had before me, which I cannot find right now, a list of the rates, the hourly rates. If I can't find it within the next 2 or 3 minutes, we'll have to propose that the physician look it up on the website.
Okay, do you want me to go? I can go on to another question for now.
I'll just answer that. It's $151 per hour.
Thanks, Todd.
What if we have medical notes or services that are privately billed or uninsured services?
Insured services. Todd, do you have an answer for that one?
Those services should be assigned to the health authority, billed and assigned.
Please clarify the fee-for-service assignment to the health authority. Is this assignment applicable after terminating the contract? If yes, does it mean that the health authority now pays the physician or the clinic directly?
I stand to be corrected by the technical experts here, but the idea is for that billing and assignment to happen at the same time that the contract runs. So the notion is that the physician is no longer billing and being paid fee for service. That physician is being paid hourly for the services provided. However, the services are being provided and recorded, it can be recorded in fee for service, and there's a payment that happens associated with those services. What we want is for the physician to say, I'm not taking those fee for service payments, I'm going to give them to the health authority, because instead of relying on them, I'm relying on hourly payments.
Yes, that's correct, Paul. And so the assignment would only apply during the term of the actual contract. If the physician goes off of the contract, they would continue on fee for service and then retain those billings again like they did previously, and no longer assign those to the health authority.
Okay, thank you. Is there a requirement for patient panel size?
The patient panel size requirements that reside in the other family practice contracts that we've identified. Here, the requirement is associated with the hours provided for the services provided to patients. There are no references to patient panels in the contract.
I think the other thing I would just add to this, which we referenced earlier, this is really a mechanism for existing physicians who are practicing and have been impacted because of the pandemic. So it's about the sort of historical services that have been provided, being maintained just through a different payment model. It's not, as Paul kind of intimated, it would need to be some discussion around a physician who doesn't have an existing practice or a practice pattern moving on to this. We would have to work through that probably in some detail to consider it.
Okay, thank you. How were the salary amounts determined? The rate for my specialty and for many others are at the bottom quartile for our specialty.
There was a lot of discussion about appropriate rates in the contract, and what we used as a guide for the rates were the rates that were set out in the PMA. And following the consultation, the decision was made that we pay at 90%. So it's consistent, the payment rate is consistent with respect to the service contract rates that are set out in the PMA.
Okay, thank you. Does the health authority pay the doctor directly, or is payment made to the clinic the doctor works in?
As distinct from the contracts, the group contract, this is clearly a family physician asking the question. As distinct from the group service contract, the payments are made directly to the physician who signs the contract with the health authority.
Okay, thank you. What about ICBC fees?
That would be billed and assigned. Only WorkSafe. Only WorkSafe is carved out of the contract.
Thank you. Are physicians who work in community offices and not attached to a hospital eligible for these contracts?
Yes.
Yeah.
Okay. So therefore, physicians don't necessarily have to have hospital privileges.
There is no reference to hospital privileges in the contract. The reference was to maintaining the services already historically provided.
Okay. How do we bill out-of-province patients while on this contract?
My presumption here, Todd, perhaps tell me if I'm wrong here, is by the hour.
Well, you would bill the same way that you're currently billing for out-of-province patients.
Okay, thank you. How would this contract be advantageous to family physicians in comparison to the group contract or full service family physicians that was discussed during webinar last week? It's confusing that both these contracts are being offered at the same time.
So perhaps it is confusing that they're being offered at the same time, but the purpose is entirely different. The contracts that we've negotiated for family practice, both the new to practice contract and the group contract, are ongoing commitments to facilitate a change in how physicians practice, where physicians are interested in practicing along the lines of the services that we're looking at, full service, patient medical home kinds of practices. Whereas the COVID contract, applicable to a much broader range of physicians, not just family practice, is there to protect physicians, to provide an incentive for physicians to continue to provide services while their income may be affected by COVID. So there are two different purposes. We happen to be launching them at the same time. Perhaps an opportunity for physicians on fee-for-service to take advantage of the group contract rather than the COVID contract at this time.
Can I say, I think it's important to understand that Doctors of BC supports a plurality of payment mechanisms. And we've always felt that physicians deserve a choice in how they are paid. Some types of pay are going to work better for some people than others. As Paul said, the intent of the family practice contracts that we talked about last week is completely different. It's meant to be a long-term alternative and practice in a different way, change the culture of how we support family physicians in longitudinal care in group practices. The COVID contracts were designed to meet a particular need, and probably they're more suitable for proceduralists than anybody else that we've talked about here. We didn't think it was fair to not offer them to everybody, but you have to look seriously at whether they're going to suit your practice or not. It'll be different for every particular individual circumstance.
Okay, thank you. The reduced hours will be because of reduced patient volume due to COVID. So how does the contract make up then for reduced patient volume?
I think there's several parts of the answer. One part is that they do provide a physician to perhaps take a bit more time providing services according to the standards outlined by the college. Secondly, they do provide payment for administrative time, which might not otherwise be considered a part of what fee-for-service entails. And thirdly, there is the opportunity for a physician to take some time, planning time, administrative time, to consider how the office may be reconfigured, as Mark mentioned earlier, to offer services in a more effective fashion under an hourly paid contract with a different arrangement with patients than under fee-for-service. But this contract does not provide payment for time where services under the contract are not provided. And so there is going to be an impact of a service reduction on this contract or a volume reduction on this contract as well. But as Trina said, one of our major objectives in participating in these discussions was to put a new contract option on the table for physicians to consider. It may not be better than fee for service, but it might, and it's worth looking at.
Okay, thank you. Do I understand here that a physician working in a practice choosing this hourly contract arrangement could no longer work in a walk-in urgent care clinic, as he could not bill and support overhead of urgent care clinic? We could not provide our 7-day-a-week access if this was the case, and this past weekend there would be no doctor available outside the ER or primary care clinic available.
And I think the question is a bit complex, but the idea of a physician that may work in multiple clinics who signs on to the contract is that this hourly rate would be paid for all of the services, all of the locations of the services that are being provided. The physician, though, whether paid under this contract or under fee for service, would have to continue to fund overhead from the income that is provided under the contract. That might have an impact on whether a physician is interested in moving to this contract, but that's a characteristic of the contract. If you have to pay overhead to a walk-in clinic on day 1 under fee for service, on day 2 under this contract, there would still be a requirement to provide overhead funding. Perhaps it might require a different discussion with the clinic operator.
Thank you. If the university pays me a sessional rate for teaching a medical trainee, can I still count those hours under the contract?
So now we're talking about funding for clinical services that are paid by the university. To be honest, I don't think we considered that, unless Todd, you have a different perspective here, but I don't know that we'd considered how payment for clinical teaching would be affected under this contract. Todd, did we cover that? Do you recall?
Yes, the contract covers teaching provided concurrent with patient care. So that is bedside teaching, undergraduate clinical teaching, core resident clinical teaching, subspecialty resident fellow clinical teaching, and teaching of other physicians and other health professionals clinical teaching.
Mm-hmm. The question there would be, how would the physician be able to bill and assign those payments?
So the payments from the university would stop under the clinical faculty appointment. If you are compensated under a contract, the health authority stops paying.
Yeah, that is a condition. That is a condition that relates to the compensation terms for clinical faculty with the Faculty of Medicine, which is that the payments for clinical services don't flow to physicians who are under a contract to provide those services. That would make those physicians ineligible for clinical faculty payments from the Faculty of Medicine.
Thank you. If I'm in the operating room from 8:30 to 3:30, am I paid for those hours or only for the time the surgery is underway and not for the anesthesia and changeover time?
Sorry, I think, can you read that again, please?
Yep. If I'm in the operating room from 8:30 to 3:30, am I paid for those hours or only for the time the surgery is underway and not for the anesthesia and changeover time?
So the guidelines that we're preparing here is that a physician can start to bill when they are required to provide services associated with patients and stop billing after all of those services have been concluded. But the procedures, the time for the procedures is inclusive of time spent donning and doffing and waiting for operating room to be cleared of aerosolized particles before and after a surgery. So I think unless there is something like 5 or 6 hours between surgeries, to the extent that a physician is coming in for consecutive surgeries, I expect that the payment would be continuous, unless, of course, the physician was taking time off for lunch. But perhaps, Ina, you could comment on that.
Yes, Paul, that would be my understanding as well. I mean, again, it's anything related to the services, whether that be direct patient care or indirect patient care, which includes things like handovers and includes things like meetings around patient care, etc. So all of those kinds of things are included in the contract. So yes, I mean, my assumption would be if you're in the OR for those hours, then those are, you're effectively providing services for all of those hours and they would be covered. As Paul said, I mean, if there's a large break or you're off taking lunch, that would not count. But things like, handover, anesthesia, etc., that's all related to either direct or indirect patient care.
Thank you. If indirect patient care falls into the remunerated work types, how do we account for indirect patient care, for example, reviewing of labs and reports, if there is no fee-for-service billing codes to currently bill and thereby report the time spent completing those activities?
So the intention under the contract is to report for the indirect hours that are provided and allowed for under the contract. If there is no fee-for-service code to bill and assign, then the physician isn't required to bill and assign a fee-for-service code. So there is a bit of the contract does cover a greater range of indirect patient care and administrative services than one might consider directly related to fee-for-service. But as long as it's an hour provided for services under the contract, a physician can report that and those hours will be paid. The requirement to bill fee-for-service is, of course, only related to MSP fees. Required to bill and assign is only related to MSP fees associated with the services.
Okay, thank you. I am currently working with a long-term locum who helps me to provide care to my patient panel. She does most of the face-to-face in-office visits. If I only provide most virtual visits, are we both qualified to enter into the simplified COVID contracts?
I think I'm on uncertain ground here. The general intention is not to permit two kinds of billing for two billings for one service, although it sounds like I don't fully understand the question. To the extent that it's currently happening and currently being allowed to be billed by two people, that might create an opening. But I might have to take a closer look at that question before answering it. I don't know if there's somebody else that can comment on that.
Well, I think it means that one person is doing the virtual visits and the other one is doing the face-to-face, and they'd be billing the appropriate fee for each of them. Whether they both qualify would depend on the number of hours, because it's an hours-based contract, right? So it would be the total hours of service provided.
I would, from the ministry's end, I think it would be worth a dialogue on this one, Paul, and providing a more formal response on it. We did have some discussion about that there was an expectation that appropriate care was provided, that it was based on sort of inpatient, in-clinic and the opportunity for virtual. I don't think we contemplated that there would be a circumstance where there would be a shared panel and one physician providing the face-to-face and the other physician predominantly providing virtual. So I think we just need to talk that through a little bit and what really mean.
Okay, thank you. So we have time for one last question. If a surgeon isn't operating because the OR is closed due to COVID, how will this contract help me?
To be honest, I don't know that there is a general answer to that question. The contract is helpful to the extent that there are services that can be billed under the contract. The contract does allow for a broader range of activities to be billed than simply surgery. But unless there are some specific services that can be billed under the contract, it may not be helpful. So I think a physician has to take a look at what that physician can provide. There may be opportunities to provide services to patients that aren't necessary for surgeons that aren't necessarily related to surgery. For instance, assisting a hospital in identifying priorities for surgeries upon return. But that will be specifically dependent upon particular cases.
Okay.
I think the other thing I would just add, and obviously I have no crystal ball on, the presentation of COVID across the province, but what I can say is we've learned a lot as a system since the spring, and there is no contemplated strategy to unilaterally close down and decant beds or stop surgeries. There's, I guess, a theoretical possibility in the case of a significant surge in a particular community or a outbreak at a site that things may be temporarily interrupted, but it's been very clear from the government that we are to maintain services as well as manage COVID as a chronic condition that we need. So we have to find a way to balance the two of them. So I don't think we're going to see, I'd be very surprised if we saw anything like what we saw in the spring. That was a conscious decision to pause scheduled services, to decant people out of hospitals, to free up significant capacity. There is no comparable strategy being contemplated now because we've learned so much, and we need to maintain both sides of our health system.
Okay, thank you very much. And thank you very much, everyone, for joining us tonight. Our time is up, and there are still quite a few questions remaining, so we are not going to be able to get to them all. So presuming your question was not asked anonymously, you will receive an email answer back soon. As well, one of our regional advisors and advocates may reach out to you if the answer to your question is more complex that can easily be answered by email. Please note that you can access the background information and contracts themselves on the Doctors of BC website. So we hope you have found this webinar helpful and informative. A reminder that this webinar has been recorded and will be available, and it will be posted to our website in the next day or so. And again, if you have any questions that you think of later, please email them to negotiations@doctorsofbc.ca. Wishing you a very good rest of your evening. Good night.
Thanks, everyone. Bye for now.
Thank you.